Okay, can everybody see the slides that's being presented? If people could, it would be a good idea to try to log into the Poll Everywhere polling software. This is going to be an interactive session. The easiest way to do that is to, let me put on a highlighter. Is to try to use your phone to acquire the QR code in the top right. Otherwise, you can use a web browser to go to Poll Everywhere or pollev.com/Masek. And that will be the polling questions for today's webinar. We will be giving people a couple of minutes to get on the slideshow or get on the webinar. Okay, it's 12 o'clock. We're going to give people 2 minutes to get on. If people could just verify that the polling software is working by clicking yes to the poll that's up, that'd be really helpful. Oh, it was on instructions. All right, it's now 2 minutes after 12, so good afternoon, everyone. We're going to begin the webinar right now. So today's webinar session is going to be about a steward's guide to guidelines. So how to use them, how to make them, and the common utility of guidelines with some problems that I think a lot of stewards encounter. This is a presentation from the Missouri Antimicrobial Stewardship Educational Collaborative. I am Dr. Kevin Hsueh. I am an associate professor of medicine in the Division of Infectious Disease at Washington University School of Medicine. Online, you will also see Erin Rockmiel, who is an antimicrobial stewardship pharmacist for the Washington University School of Medicine as well. We are both here as part of a contract with the Missouri Department of Health and Senior Services, who is sponsoring this effort to try to improve antimicrobial stewardship throughout Missouri State. So today's webinar will be a brief orientation to MASEC and a welcome to our newest members. We had a lot of new people interested in the program. And then we will go on to why we should be focusing on guidelines, at least in part for our activity, the role of guidelines in antimicrobial stewardship, and how to develop a facility-specific guideline, sort of walking through the individual steps, and then moving towards common stewardship dilemmas where guidelines can and are useful, especially in the acute care hospital setting. During this whole time, we will be asking what people would like to hear next. And people can put that either in the webinar chat on Zoom or on some of the polls that the Poll Everywhere software is going to present. We will be collecting both. Just FYI, this webinar is going to be recorded so that hopefully we can provide it to people who weren't able to attend. Just some disclosures. As I said, this webinar is supported by the Missouri Department of Health and Senior Services, their HAI and AR resistance program, with help from a Centers for Disease Control and Prevention grant. I am a career hospital antimicrobial steward. And both me and Erin are recipients of occasional medical care, so we do have an interest in making sure that medical care is as good as possible. This is an interactive session. We can definitely stop and answer questions if people have them. Erin, please monitor the participants if somebody raises their hand and just ping me. If you want to put any questions, thoughts, or recommendations in the Zoom chat, please do so. And then, as I said, Poll Everywhere is going to be used specifically for the case questions and feedback. This is going to be a partially case-based presentation. So first, since there are a lot of new people on the line, I wanted to introduce who and what MASEC is. So this is very condensed from the last time we had it, but MASEC is a statewide stewardship educational effort sponsored by the Missouri Department of Health and Senior Services. Its goal is really to distribute stewardship expertise, disseminate successful practices, support stewardship program development at facilities throughout the state, and provide a one-stop stewardship consultation resource to people throughout Missouri. One that's not sort of constrained by contracts and payment. We're also going to be helping the DHSS identify areas that they might be able to provide assistance. So common issues that facilities throughout the state are dealing with. Most of the time, you will be dealing with the core MASEC working group, though we do have other physicians and professors and staff working on the project. Myself, I am an associate professor of medicine over at in the Division of Infectious Disease at Washington University School of Medicine. I've been performing antimicrobial stewardship for around 10 years at this point. Erin is one of our pharmacists, a stewardship pharmacist, and she has been working both on at local antimicrobial stewardship and sort of a networked hospital stewardship. Tracy Habrock-Bach, who may also be responding to emails, is our project coordinator, and she's really able to get in touch with whoever you need to get in touch with. Just FYI, these are the services that MASEC provides. So we are, you're at one right now, but we're holding webinars around every quarter based on questions and concerns from MASEC members. So some people will notice that we are addressing questions that they have specifically posed to us during this webinar. And really, that's where we're hoping to get most of the sort of issues that we try to deal with, because we're not just trying to present information to you, but also get back what questions are being asked. We are also, and this is a new effort for this year, providing a stewardship program, counseling/intervention training program. So these are individual consultations with our team. Right now, we have around 3 or 4 hospitals participating. Just FYI, this is relatively bandwidth intensive, so this is a first come, first serve program. We'll probably max out at some point if we get a lot of interest. But if you are interested in this kind of training program, basically we're helping walk people through developing a program, developing and implementing interventions. Please email us at themoststewardship@worcester.edu email resource. This is the one-stop place to contact us. It's the best way to contact us because someone's always staffing that line. It's not real time though, so and this is really not for clinical consultations. If you have clinical questions, especially ones that are timely, unfortunately, we are not staffed to respond to that at this point in time. We're also providing educational and reference materials in a website that is in the process of being developed. So this is where you guys get to participate. So for new and old members, please put in poll everywhere the questions, problems, challenges you are most interested in getting help with, or that you are having the biggest problem facing. This poll will be open now, and then when it closes, when other polls open, you will please put them in the meeting chat. So let's go on to the use of guidelines in antimicrobial stewardship. So I think everyone has encountered clinical guidelines either in their training or in their day-to-day use, and it really has a significant clinical impact. I don't think that's really doubted anywhere. They help remind providers on details around identifying the correct diagnoses and figuring out treatment decisions based around that. Things that I think should be emphasized is they can really highlight diagnoses where antimicrobial therapy is not indicated, especially for antimicrobial stewardship. So anybody who's trying to deal with respiratory tract infections, really emphasizing that viral upper respiratory tract infections are not an appropriate target for antimicrobial therapy. It doesn't really do anything. It can often cause harm, even if it's relatively infrequent. It guides people through an appropriate workup, identifying diagnostic testing that is appropriate, helping avoid diagnostic tests that are inappropriate. And the number of times I see urinalyses and urine cultures done for people with no urinary symptoms tells me that this is an incredibly important aspect of medicine. It can reduce, because of that, it reduces false positives and false negatives. And it can, for the stewards among us, it can include testing recommendations that will help with de-escalation further down the line. So even if you can't prevent empiric initiation of antibiotics, you can at least help them get the information that will sort of encourage more rapid de-escalation. It also helps people choose the agents with an appropriate spectrum and efficacy for the specific disease and severity that's being treated. So, for every single hospital, this is likely to be at least slightly different. There are going to be preferences for hospital and facility formularies and differences in their antibiogram and the facility population that are going to change things. You know, if you're a facility that has a ton of people with COPD or elderly from the nursing home, the most common spectrum of illness may be very different than that of a community hospital that's mostly dealing with relatively healthy younger people. It also helps set the appropriate duration, at least set the expectations of an appropriate duration. And for many diagnoses, many common diagnoses, this has decreased significantly in the last 10 years, where everything used to be 10 to 14 days. It's significantly lower now, and we'll talk about some of the cases where that is, and identifies the appropriate de-escalation timeline, when de-escalation is appropriate, and the process for doing so, and what the appropriate agents that substitute for other agents are. Unless you be, people have questions about why this is necessary. Well, a large cross-sectional study from 2015 suggested that for common indications, greater than 50% of antimicrobial use in acute care facilities was not consistent with national antimicrobial use guidelines. And this is not the first, nor is it going to be the last study that suggests this. For the antimicrobial stewards, guidelines also serve a host of administrative uses. And so these are uses that aren't specifically clinical in terms of taking care of any individual patient, but are used to facilitate the activity of an antimicrobial stewardship program. First off, it provides concrete documentation which leadership can review, discuss, and come to consensus on around what the appropriate diagnosis and treatment recommendations are for a specific condition. You'd be surprised at the sort of debate still going on around what is appropriate in terms of diagnostic procedures for the treatment of things like urinary tract infection and community-acquired pneumonia. Even though those are probably some of the most common infections encountered in medicine, they are still hotly debated even among experts within the field. It provides a framework for the measurement and monitoring of antimicrobial therapy. And we'll go into this in a little bit more depth, but you need to have what you expect in order to figure out if a provider is deviating from expectations, deviating from adherence, or following the accepted guidelines at your hospital. And really that you can't do that if you don't have a document that suggests what they should be doing. It allows specific appropriate use cases for antimicrobials to be identified for high risk and high cost agents. So I think one of the problems I think we all run into is that people get used to using very broad spectrum, sometimes extremely expensive agents for almost everything, especially in training. And it's hard to rein them in. And this allows you to identify when that usage is actually appropriate. It allows your hospital to identify specific preferred agents that are the approved or accepted agents for any particular indication at your institution. Everybody has a slightly different formulary based on what what your acquisitions department is able to acquire and the prices and everything like that. It also details a framework. I think I doubled this up, but basically, yes. It allows you to guide evaluation of provider actions to see whether they're adherent or not. And last but not least, it allows you to literally hand something to regulatory bodies, TJC, CMS, state licensure just being some of them, which can confirm that you are compliant with requirements, regulatory requirements. Needless to say, one of the reasons why we are focusing on this today is that this is now a mandated intervention, antimicrobial stewardship intervention. So the most clearly focused on this is the TJC Medication Management Standard EP19, 991 EP19, which was updated in 2023, which requires that every hospital, a very acute care facility, have at least 2 evidence-based guidelines to improve antimicrobial use for common indications. They identified examples of this as possibly community-acquired pneumonia, urinary tract infections, skin soft tissue structure infections, C. difficile colitis, asymptomatic bacteria, IV to PO conversion, and surgical antimicrobial prophylaxis. Really call out that guidelines need to be based on national guidelines, but also can be tailored to local susceptibilities, formulary, and the type of patients being served. CMS is a little bit more vague about this. In 2020, the new CMS antimicrobial stewardship condition of participation was released, but then in 2022, they released an interpretive guidance to that, which really one of them says that hospital-wide stewardship programs need to document the evidence-based usage of antimicrobials in all departments and services. If you're reading between the lines, that means you have to have interventions that reduce adverse events related to antimicrobials, but that you have to have a guidance on what is evidence-based usage of antibiotics. So basically, these are implying that every hospital should have their own guidelines on what is appropriate antimicrobial use. So, question for the audience: who here has created at least one hospital-specific treatment guideline at their institution? We'll give people around a minute to answer this. Oh, am I? No, we're on responses right now. I wish I could see percentages and numbers, but we'll see. Okay. So. All right, still around a quarter, or a little bit more than a quarter who haven't. And by the way, this is not uncommon, especially hospitals with non-academic hospitals. It is hard to necessarily find the staff or coordinate the development of a hospital-specific treatment guideline, especially kind of the way that people often talk about it, where it needs to be expert-based. You need to have a whole huge group to lead it. That's not always, as we're going to see, necessary, but around a quarter. All right, people can keep answering while we go forwards. So what I'm going to do right now is walk through how to identify what a good target is for creating a guideline, and then how to actually get that to the finish line from the beginning to the end. So first things first is, especially if you're starting, don't pick a really complicated condition to make a treatment guideline on. Basically, don't start with intra-abdominal infection. That's not a great idea. What I recommend is identifying where your low-hanging fruit is. So do you already regularly make uniform recommendations regarding some kind of change or appropriate use of antimicrobials that you could just formalize in writing? So oftentimes hospitals have IV to PO, routine IV to PO substitutions that they make, routine recommendations around surgical prophylaxis, specific usage guidelines around certain kinds of agents. So, and I'm going to choose this based on some questions that we've gotten, but for, say, aminoglycosides, make sure that you have guidelines saying that people who are going to be on aminoglycosides for longer than basically, 3 or 4 days need to get an audiogram, a baseline audiogram, and need to have regular peak and trough levels drawn. You'd be surprised at the times that providers just don't even realize that this is necessary for certain antimicrobials. If you don't have something that you're already doing, try to find things that you'll get the most support on. So do you have a supportive prescriber, a champion? This is language that's often used in quality improvement that has a specific topic of interest. Things that people grouse about other people misusing. Antimicrobials for community-acquired pneumonia, antimicrobials for urinary tract infections, soft tissue infections are frequent common ones. Do you have frequent interventions or overuse scenarios that we repeatedly have to deal with? If you're going to choose something, might as well choose something that you have to deal with on a frequent basis. People have mentioned things like, soft tissue ulcers. How do you deal with those? If you're, that's to identify what low-hanging fruit there is. But otherwise, you should also consider, is it something that you can easily monitor compliance with? So there are certain agents like nitrofurantoin that are only used in urinary tract infections. And so it's a lot easier to monitor usage and compliance with urinary tract infection guidance if it's focusing a lot on the use of nitrofurantoin, because there's no other real use for it. And then lastly, if there's, beyond all that, if there's a target that will involve or interest a facility leader that you want to be interested in antimicrobial stewardship, that's also a good target. Realize that everything we do has sort of knock-on effects, and if you can get somebody interested in your activity, you're much more likely to be successful long-term, even if it is maybe something more complex. Also things that are, particularly interested, that leadership is particularly interested in addressing. So high-cost agents, and we'll go into one of them, is always a target of convenience. So once you've identified a target, what do you do next? Well, first off, you want to do some preliminary data collection if you can. So try to map out how you are going to monitor or evaluate adherence. And I strongly recommend starting pre-intervention data collection if you can, because trying to retrospectively figure out what your impact is always much more difficult than trying to do it starting before you start the intervention. So say, usage of linezolid. We want to at least start collecting how frequently your prescribers are prescribing linezolid. Step one after that, after you've identified your target, is to survey the approval landscape and get preliminary assent for you actually doing this. So you generally don't want to surprise people about the development of a guideline, because that's an easy way to get automatic defensive no's. What you want to do is get people aware that it's happening, get their tacit assent for your activity before you go too far. It also will keep you from getting basically, pushback at the end after so much work. So discuss with your leadership, confirm how you would get approval for a guideline. So generally that goes through the Pharmacy and Therapeutics Committee, but there are other modalities. So sometimes it's through quality improvement, the Quality Improvement Department. Sometimes it's through patient safety. Sometimes it's through the medical directorate. There are multiple ways sometimes that guidelines get approved. That doesn't mean any one is wrong. It just means that you have to figure out how it works at your hospital. And sometimes, especially if your hospital doesn't have many guidelines, they don't know. And so you have to map out how that actually works. Also, identify wider stakeholders that need to get sign-off prior to approval, that you need to get their affirmation that this is a good guideline. So generally, that would be departmental leadership that is affected by the guideline. So, if you're making surgical prophylaxis recommendations, you would probably want to have your surgical leadership aware and approving of the recommendations. And that also, I strongly recommend that anybody who is a thought leader at your institution, somebody who basically, what they say other physicians take with a significant amount of authority, you want them to probably have looked at it and approved of it as well. Step two is forming a working group. And I strongly recommend not oversizing this working group, even though it sometimes it can be helpful to have a lot of people involved. It is often extremely unwieldy to have more than 3 or 4 people involved in the creation of a guideline in general. Not saying that you won't have more than 3 or 4 people review it and approve of it, but you don't want them working on the text because it will take forever. And oftentimes people go round and round and round with the same questions over and over again, especially when they're trying to figure out the questions to ask. What I recommend is have a topical expert if you can. Often that's a physician champion, but especially at smaller institutions that you may not even have that. And then if there's diagnostic test questions, you're going to want to at least ping laboratory expertise on that. So just make sure that you're recommending tests that your institution has and has available and has, as a recommended test. You don't want to encourage this use of send-out tests all the time. Once you do that, then you guys review and import recommendations from national guidelines. Generally, things from the CDC, from the Infectious Disease Society of America and Hsueh tend to be pretty good for infection-related treatment. The American Society of Health Systems Pharmacists is also a really good resource, but there are a lot of others based on what the topic is. So for pneumonia, it's the American Thoracic Society, the American Heart Association for endocarditis or bloodstream infections. NIH also has some guidance. COVID, actually, the NIH stepped up and produced a lot of guidance documents. And then for surgery, it's the I can't remember what SIS stands for. As like Surgical Infection Society, I think. But there are many others. So we'll talk, just responding to some of the questions. We'll talk a little bit at the end about long-term care. While it is not required by, as far as I know, any guidelines organizations at the moment, the thing is that long-term care and longer-term care facilities actually have some of the biggest challenges with antimicrobial overuse, because you have a very often elderly, debilitated population that gets certain kinds of infections very frequently. And quite honestly, at least from the other side, we see often very kind of haphazard usage of antimicrobials. So even though you don't necessarily have a mandate to do so, you may want to select at least something relatively straightforward, like, there's a lot of depth to this, but urinary tract infections aren't really the most straightforward, but they are often one of the biggest challenges, to at least make sure that people are doing the appropriate workup and assessing people in a way that is actually relatively concordant. And when things fail, that they fail not because somebody forgot to do some testing or forgot or treated something that they didn't need to, but it actually follow the appropriate utilization and diagnostic guidelines. So step 4 is customize that guideline for your facility. Remove agents that aren't on your formulary, highlight preferred agents, remove diagnostic recommendations that are not really appropriate for your hospital, add diagnostic recommendations that you want people to routinely do. So sometimes it's sputum culture. Often we'll talk a lot about the use of nasal MRSA screening to facilitate vancomycin de-escalation. Review your antibiogram if you have one to ensure the spectra are appropriate, and consider your patient population. So if you have a patient population that is essentially, 100% risk for MRSA, you're probably going to focus a little bit more on empiric coverage for that. I don't know of any population that would be like that, but I'm not aware of every population in Missouri. Drill down and try to simplify things that are the most frequent. If you have a guideline that is too broad, sometimes it is not useful for anybody. What we often see is that people try to create guidelines that are useful for every possible scenario, and they become useless for all the scenarios in general because they're too complicated. Once you've done that, have stakeholders review and sign off on your guidelines. So discuss, they're going to probably raise some issues, discuss them, and then revise the treatment guideline based on the issues that are raised. You are often going to get people identifying, subpopulations or edge cases that they want to discuss, and you can often write those into caveats. So, if you have a highly immunocompromised group or ventilator-dependent group, write that into the guidelines, and basically say they do not apply to those people, just to make sure that you address the questions. You don't generally want to just say, no, we're not going to make that change. It's not really helpful and often gets auto pushback. And then last but not least, you're going to submit it to your approval body, often P&T, and hopefully if you've done your groundwork, gotten stakeholder review and sign off, that should not be a problem getting through. Once you've gotten approval for the guideline, now comes actually often the more challenging part. So this is communicating the new guidelines to everybody. Easiest is always facility-wide broadcast emails and newsletters, but communicating to your specific departments and staff is actually really helpful. it allows you to build sort of champions and stakeholders there, and presenting at departmental meetings is often more useful in terms of getting people aware of things than emails. Emails, as everybody can tell, just easy to just forget that you've been sent them. Communicate with other departments, pharmacy and nursing, and then if you can, try to identify a way to distribute them on an ongoing basis. So oftentimes with smaller facilities, this is just going to be physical flyers, and that's perfectly fine. If you have a couple of floors that you just need to post these guidelines on, that's pretty easy. But if you're a larger institution, then you might want to find, and especially for things like TJC documentation, you're going to want to find a repository site for these guidelines and your other policy documents for antimicrobial stewardship. So this can be a website, a shared drive, a SharePoint, policy warehouses, because most larger institutions have some kind of policy repository. And then if you can't find that, intermittent update emails may also help, where you send them out to everybody just to make sure that everybody's got at least one email regarding your general guidelines. And then, because PDFs are not usually that big. If you're really sophisticated, you can get things integrated into the EMR through links and documents. The only EMR that I know that's really this particularly easy in is Epic. And even then, it's not that easy. Consider that an advanced integration. And even more advanced over that is somehow integrating the recommendations into the EMR or computerized order entry system, which is often adapting it into an order set and using it as the basis for decision support alerts. So, having that be the basis for certain antimicrobial timeouts or de-escalation recommendations that flash on the screen when a certain time period is left has been met. I generally consider these extremely advanced interventions. They are very time-consuming and often completely beholden to IT and your IT resources on whether or not you can do them. Once you've gotten all that done, now comes the tracking part of things. And this is a required component of TJC and CMS. So one thing you have to realize is neither of these bodies, and quite honestly, nobody has reached consensus on whether or not you need to track appropriate use on an individual prescriber level or whether or not you can track things on a group level. Quite honestly, the goal, I think, at the end of, in several years would probably be to individually track everything on a prescriber level. That is generally not feasible right now with most EMRs. So most people are just tracking things on group levels, through cohort analysis, basically. What you're gonna probably want to do is do spot checks. So set aside a certain period of time, say a week, and look at charts through that week with the particular diagnosis that you're concerned about, say community-acquired pneumonia, and then just track how many times providers have been adherent, as far as you can tell from chart review, to the guidelines versus not adherent. That will generally give you some indication. If you can, use either order indications or order set utilization or billing codes or primary admission problems to make this as easy as possible. It's not a low effort process, but it can be made lower effort than just literally, looking up every single person's chart. As I said, I recommend gathering baseline data for comparison. But the one thing that sort of is no longer recommended is just trending overall antimicrobial use. It doesn't really track adherence for specific conditions. And then since you're going to do all this work, report it. Report it to PAT in your ASP work groups, to your medical staff, to your administration, because they A, need to know what kind of activities you are doing, and B, it may help change prescriber habits going forwards. All right, so now we'll get to the cases. So let's start with case 1. And please, I'm interested to see how often people are encountering certain kinds of responses to antimicrobial overuse. So this is case 1, which I call I need to complete a course of vancomycin. The patient's a 48-year-old man. He's a smoker with a history of alcohol use, arrives at the hospital from home after 1 week of history, a 1-week history of progressive cough and shortness of breath with subjective fever and chills. Pretty classic. He's slightly febrile, 100.8. His pulse is 90, blood pressure 148/85. He's got a respiratory rate of 25. He's breathing kind of hard. That may have to do with his smoking history. His O2 sat is 90%. His labs, he has a white count of 12.5, a creatinine of 1.4. This trends down to 1.2 after fluids. And he has started on vancomycin IV in the ED, admitted, defervesces on hospital day 2, and now it is hospital day 4, and antimicrobial stewardship, or pharmacy in general, is being called to request PO equivalents for vancomycin for discharge. So let's see how many people are encountering certain things. I can't stop MRSA and resistant gram-negative coverage because the patient got better on them. It looks about like half of the respondents, or a little bit more than half, have seen this. I'm planning on a 14-day course of antibiotics for pneumonia. The fact that basically everybody who's responded is seeing that is concerning. I didn't get cultures because the patient wasn't making sputum. I guess that's just on my institution. I can't de-escalate agents because the patient's about to be discharged home. So that is definitely a common response. And then we started vancomycin because he looked sick, but he didn't necessarily. So you guys can continue to answer this while we're going through how to use guidelines to hopefully prevent this problem from happening in the first place. So, and the problem being, it is very hard to immediately de-escalate off vancomycin and cefepime. There aren't very many vancomycin alternatives that are perfectly matched to vancomycin. There are even fewer direct cefepime equivalents. So how do you use guidelines to encourage de-escalation? Well, first, of course, look at the guideline that you're talking about. So in this case, it would be the community-acquired pneumonia guideline that was released in 2019 by the American Thoracic Society and the Infectious Disease Society of America. And it is a long guideline. So IDSA is actually very well aware of this and well aware that it's kind of cumbersome. So they are in the process of creating a sort of more easily adaptable decision tree, decision matrix, which will hopefully allow people to adopt these guidelines a little bit easier. But the most important thing about the new community-acquired pneumonia guidelines is that they are no longer identifying HCAP, healthcare community-acquired and healthcare-associated community-acquired pneumonia, as a category. Now it's been basically all rolled into community-acquired pneumonia. What they realized was that their previous attempts to use HCAP to identify people who are at risk for resistant pathogens was overly broad. Basically, everybody who had been in or around healthcare for the last 3 months prior to their admission were getting vancomycin and cefepime, which was really not the intent, and very, very few of those patients actually needed vancomycin and cefepime. So really now the only gradations for pneumonia are community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-associated pneumonia. So the new upcoming IDSA CAP guidelines, I'm just going to use an example. These should be coming out relatively soon, within the next few months. I was involved in the development of them. So basically, they walk through how to approach these kinds of patients. So when the patient comes in, are they hypoxic? Do they have some criteria for admission? If not, then they should really be treated outpatient. But the things that they really focus on in the beginning is grading the severity of illness, so categorizing whether or not the CAP is severe or non-severe, and then identifying the kinds of diagnostic testing that is appropriate for that. And so just FYI, the CAP severity gradations really are pretty stringent. So a patient has to be in septic shock or respiratory failure to meet them, or have 3 of the following minor criterion. So a respiratory rate greater than 30, multilever infiltrates, low FiO2, hypothermic, leukopenic, have extremely high BUN, or hypotensive. So most of those, so this patient met none of those. And then it breaks down recommendations based on whether or not somebody is non-severe or severe. So in terms of diagnostics, it recommends not doing blood cultures, not doing respiratory cultures, unless you have some concern that the person has resistant bacteria. So hospitalization in the last 90 days, anti-MRSA or anti-Pseudomonal coverage is going to be started. Advanced structural lung disease is present. Or if you have severe CAP, basically you should do it all the time. And it recommends the MRSA nasal swab, which is a marker of MRSA nasal colonization, if the person is basically at minor risk for antimicrobial resistance or anti-MRSA coverage is being started. And then based on whether or not a person has MRSA risk factors or Pseudomonal risk factors, that's how people are shuttled into getting MRSA coverage, so vancomycin generally, or Pseudomonal coverage, as you can see here. And so most of the patients are unless they have these high-level risk factors for antimicrobial resistant organisms, should be shuttled to a basic beta-lactam and macrolide combination. So basically ceftriaxone and azithromycin for the most part. And this is completely concordant to those CAP guidelines that were released in 2019. So it's a little bit harder to understand here, and unfortunately, this is a little bit of a degraded image. But yeah, treatment of MRSA or coverage for MRSA and Pseudomonas is really only supposed to be for people with risk factors for MRSA or Pseudomonas, which is not most of most patients, or if the patient is has severe pneumonia, where you really can't take the sort of, you have to cover immediately and you can't have even a moment's delay. In terms of the role of sputum and blood cultures, well, it tries to identify when that would be appropriate. So severe disease, generally, or if you have disease where you're going to be treating for MRSA or Pseudomonas. So basically trying to identify patients where the sputum and blood culture results are going to be used, and excluding those where it's not going to make a difference in terms of the treatment regimen. So a slight digression to the use of MRSA nasal swabs. So this is based on some studies done in the 2010s, which showed that negative MRSA nasal swabs for community-acquired pneumonia had a greater than 95% negative predictive value in community-acquired pneumonia. So if you had a MRSA nasal swab on admission and it was negative, you were very unlikely to have an MRSA pneumonia. And really anybody, general recommendations at this point is that if you have that capability within your hospital, anybody who's getting anti-MRSA coverage started, so anybody who's getting started on Vanco for community-acquired pneumonia should probably be getting an MRSA nasal swab to help with discontinuation going forwards. Just a caveat, positive MRSA nasal swab doesn't really mean too much. It's only got a 40% positive predictive value. Basically, it raises it from probably 20% to a little bit more than 30 or 40%. So it wouldn't be a huge fact. It's not something that you can easily rely on to say that somebody got a MRSA pneumonia. But the other thing that the upcoming IDSA CAP guidelines do is focuses on follow-up. So what do you do once you selected empiric coverage? Well, it talks about how you respond to diagnostic testing. So about the MRSA nasal swab, and that if it's negative, you can discontinue MRSA coverage pretty easily, but also, trying to overall minimize broad antimicrobial coverage and discontinuing antimicrobial therapy with positive viral diagnostics, but also when it is appropriate to de-escalate off of the broader empiric coverage. So when our patients are afebrile with at least 5 signs of CAP stability, which are in a separate list, but basically this patient would have met at the moment that they no longer were febrile, and the kinds of oral agents that are appropriate. So augmentin, cefidoxime, ceftriaxone, levofloxacin if they have MDR risk factors, and the duration. So I noticed pretty much everybody said 14 days. Well, really, generally for community-acquired pneumonia, no more than 3 to 5 days is really necessary anymore. And multiple studies have shown there's really no difference for a long course versus a short course. And probably there are some antimicrobial-related adverse events that are occurring as well. So how could implementing those guidelines have addressed this particular case? Well, if you look at it, this person came in, classic story for community-acquired pneumonia, but they didn't have really any of the markers for severe pneumonia. This person should never really have been started and came from home. So he may have structural lung disease, so cefepime might have been appropriate, but vancomycin generally would not have been. Even if the provider made the decision that, they still thought vanc and cefepime were appropriate, the recommendations would have suggested that they should have gotten a MRSA NARS swab. And by hospital day 4, you would probably have those results back and could easily recommend the discontinuation of vancomycin at that point because the MRSA NARS swab would be negative. And then because the patient was stable, de-escalating off cefepime would have been easy. And then, of course, unless people had, hopefully people had noticed, but this person wasn't started on atypical coverage, which they probably should have been, but it would have been vanc, cefepime, and either azithromycin or doxycycline that was supposed to be started. So it could have prevented, incomplete or insufficient treatment. All right, so we'll go to the next case. So case 2A is what I like to call overbroad treatment of cellulitis. So this is a 54-year-old woman, history of previous breast cancer, status post left-sided mastectomy, presents with 1 day of rapid swelling of redness of the entire left arm and chest. She's got no clear abscesses or wounds on the left arm or chest, but she is febrile. She's 100.9. Other than that, she's pretty much hemodynamically and vital signs stable. 84, 120 over 70, respiratory rate 20, 99%. She is relatively young, 54. She's only got a mild white count elevation of 11.5. She's got a creatinine of her baseline of 1.1. She's on sertraline, and she's got a CT of her left arm and chest, which shows edema and soft tissue stranging, but no discrete abscesses. She also doesn't have a DVT because that's why they did it. She was started on vancomycin IV in the ED and admitted on hospital day 1. Stewardship or pharmacy is called to request initiation of daptomycin because the redness is increased and the patient's still febrile to 101. So as the person trying to respond, what would you guys recommend and for how long? This is a more complex answer, so hopefully we get some answers. All right, I'm going to let people think about that for a bit. We'll go to case 2B. These are both sort of different sides of the same coin. This is overbroad treatment of wounds. So the 76-year-old woman, history of hypertension, hyperlipidemia, Parkinson's disease, brought in by EMS due to an inability to get out of bed, found to have a large left buttock decubitus ulcer that probes down to bone. Afebrile, basically vital signs completely stable, white counts within normal limits, creatinine is 1.5, which is her baseline. She's on amlo and atorvastatin, and CT shows a full thickness ulcer of her left iliac bone. And then in the ED, a swab of the wound is sent for aerobic and anaerobic culture. Then the patient started on vanc and zosyn. Culture grows E. fecalis, Pseudomonas aeruginosa, E. aerogenes, and mixed anaerobes. On hospital day 6, prior to discharge, the ASP gets a question on oral alternatives because the subacute nursing facility that they're planning on sending this patient to will not take the patient on these agents. And so the question is, how often are you seeing these kinds of cases? And I am not surprised that you guys see them all the time. I do as well. I am very impressed when from never about never. But this, I think, is one of the most frustrating things, at least for me as an infectious disease doctor, because there's all sorts of frustrating things happening here. And so we will talk about how, I know I'm running out of time, how to use guidelines to hopefully address some of these problems. So use guidelines to really improve diagnostic approach and empiric treatment. Really, for the first case, cellulitis, the mistreatment of cellulitis, and in this case, it was very much of mistreatment. This patient didn't need vancomycin. Often starts as a misclassification, or I should say underclassification. A lot of providers don't have an understanding that cellulitis is now differentiated into non-purulent cellulitis and purulent cellulitis. Non-purulent cellulitis is almost always caused by group A or other beta hemolytic strep. Basically, things that are sensitive to basic penicillin or first-generation cephalosporins, and almost always don't need vancomycin. So mild and moderate non-purulent cellulitis don't need vancomycin. The guidelines are actually very concrete on this. They are updating these guidelines, but I do not expect this to change. In fact, I expect it to get even more narrow. Only severe, basically, somebody with an incredibly significant systemic signs of infection as well, or person who has significant MRSA risk factors like recent IV drug use would be getting vancomycin alongside it. Purulent cellulitis, where you have basically a pustule or an abscess, is almost always caused by Staph aureus, and that's when you're worried about MRSA. So that's why some type of MRSA coverage is recommended in most mild, moderate, and severe purulent cellulitis. But even then, most of the time with mild and moderate cellulitis, you only need oral antibiotics. You don't need vancomycin. Other things so adopting these kinds of guidances, and you of course can streamline this to just make it much more simple, allows you to identify things like time to response expectations. So antibiotics frequently take 24 to 48 hours to work. In particular, in cellulitis, I've seen a paradoxical worsening that occurs within 24 hours of antibiotic initiation so frequently. And this is because you get an inflammatory response when the bacteria is beginning to get killed. So you can set that as an expectation at the outset, and you don't need to keep having, hopefully, providers get sort of panicked about the fact that in the first 24 hours, the antibiotic hasn't just turned off their fever and eliminated their symptoms. You'd be surprised at how frequently people kind of expect antibiotics to work like magic. Also, you can identify how to de-escalate. So MRSA nasal colonization again, whether or not there's pending cultures from a purulent infection, and a recommendation on how and when to step down oral therapy. So it's often can be pretty rapid, especially with non-purulent cellulitis, and how long to treat for. So you really only need like 5 days, basically, for most non-purulent cellulitis, which is the majority of cellulitis as we see. Purulent is a little bit longer, 5 to 10 days after source control. So just like with pneumonia, MRSA nasal swabs have been shown to have a very significant negative predictive value with skin and soft tissue infections. So the Medical University of South Carolina Health examined all their patients from July 2014 to 20. This is where they were doing routine MRSA nasal swabs from 2016 to 2019, and they found a negative predictive value of 97.5% if MRSA was not isolated on a MRSA nasal swab. So it was very unlikely that this person would be diagnosed eventually with MRSA. So we think that it's at my institution think that this is a very good way of getting people to de-escalate off vancomycin for uncomplicated non-purulent cellulitis. So for this patient, she didn't meet she met none of the criteria for severe cellulitis. She definitely had a non-purulent cellulitis, no abscesses or wounds. And so she should have never been started on vancomycin in the first place. At the most, she should have been started on an IV cephalosporin like cefazolin. Maybe if people were feeling defensive, ceftriaxone, but that probably wouldn't be necessary. And so you wouldn't have needed to start vancomycin, and because they would have been pre-warned that the first 24 hours may show an increase in inflammation, they wouldn't have asked for an increase to daptomycin. And because the person would have been started on an oral cephalosporin, which generally has, or IV cephalosporin, which generally has an easy conversion to oral cephalosporins like Keflex, the person would have had a very easy oral transition and hopefully more rapid discharge. So for bone and joint infections, and one thing that you really need, if you're going to create a guideline around this, one thing that you should really emphasize is proper workup and procedure. So for osteomyelitis, most osteomyelitis that comes to the hospital does not need empiric antibiotics. If the patients are stable, if they are not septic, essentially, holding antibiotics is recommended in the guidelines. Even guidelines for severe infections like spinal osteomyelitis, it is recommended that you obtain appropriate specimens first. And wound swabs are not appropriate specimens for bone infections. This is a study from Taufik et al. In the Journal of Infection and Public Health, which is a nice summary, but they basically compared bone cultures to non-bone cultures. So sinus tract cultures, wound swabs, soft tissue samples, deep soft tissue samples, and needle bone biopsies. And what they found is especially wound cultures had very poor, less than 25% concordance with the bone cultures that were done. Sinus tracts, a little bit more, and bone and needle bone biopsies, definitely the highest. But soft tissue is basically the more external the culture was done, the less likely it was concordant. And if you think about this, this makes sense. All your culturing is what grows on warm, wet, proteinaceous material. And that empiric antibiotics should be the last resort. So for this patient, they should have never been started on antibiotics in the first place. Definitely not Vanc and Pip/Tazo. They shouldn't have had a wound culture done, because now that you have all these organisms, it is going to be a fight to get people not to treat them. And this is, one of the principles of antimicrobial stewardship is that diagnostic stewardship prevents the need for empiric coverage or the inappropriate use of empiric coverage. This person probably should have had no antibiotics started, a bone biopsy, or surgical debridement was sent to culture, and then, only then, antibiotics started on once the culture results. And it turns out this person had MSSA in the bone, and that all of this was probably it would cover it, but at a vast over-spectrum cost for that. All right, and then lastly, we'll talk a little bit about fidaxomicin and vancomycin. So this was a request from some of our participating institutions. So in 2021, the IDSI guidelines around the treatment of C. diff changed, recommending fidaxomicin as a preferred agent over oral vancomycin. This was very frustrating for everybody because fidaxomicin is insanely expensive compared to to vancomycin. So over Furvanc, which I think everybody may realize is the commercial expensive oral vanc, it's over 10 times the cost, and that's just bulk acquisition costs. But the studies really show a significant improvement with fidaxomicin in terms of reducing the rate of recurrence. So for basically, you only need 10 people treated to prevent a recurrence at the worst. You need 10 to treat 10 people with fidaxomicin to prevent recurrence, one recurrence of C. diff. Sorry, I'm getting a little tripped up. And in higher risk patients, people with more recurrence, that number goes down to like 2 or 3. And so this is a huge problem. Even though there are programs available to assist patients' prescriptions at discharge, and global cost effectiveness analyses favor fidaxomicin because in general, that person's going to spend in their lifetime less on healthcare costs. This really doesn't factor in the fragmentation of healthcare costs. So that hospitals are bearing the brunt of the costs in terms of starting the fidaxomicin, and that we don't get the patient assistance programs. And so hospitals are stuck in a rock and a hard place. And now I will caveat things by saying our hospital made a cost-benefit analysis of our own, and we decided that for our patients, we're going to try to use fidaxomicin up front as much as possible. But even then, we run into problems where the patients can't afford it after they are in the hospital. What some places have done, and what we did actually prior to these new studies, is trying to select populations at higher risk of recurrence to just reduce the amount of overuse of fidaxomicin and target patients that are really at high risk of recurrence. So age greater than 65 years, very high leukocytosis or other systemic signs when they initially had severe C. diff, or people who are non-severe C. diff who have very significant immunocompromising conditions. And those we preferred fidaxomicin over vancomycin, but otherwise we tried to use vancomycin as much as possible. Now, of course, this changed with the more recent guidelines, but it's still reasonable to do this kind of parsing through your guidelines in order to try to still take care of your patients clinically and still reduce their risk of recurrence, but also try to prevent this from destroying a hospital's budget. So overall, how do you use guidelines and stewardship? So we'll wrap up in just a sec. Use guidelines to shape the diagnostic and treatment process. Emphasize diagnostic testing that's necessary for that particular condition, but also things that can help with de-escalation. Really try to emphasize appropriate disease categorization and treatment and why it's different for each kind of category. And then, of course, how long to treat and what not to treat. But then also use those guidelines to serve your stewardship administrative purposes as a blueprint for your evaluation, as a tool to gain leadership trust, and to demonstrate what you are doing. So I'm a little over, but hopefully this has been helpful. Everyone can just raise their hands at this point and just speak out. I'm going to try to close in a couple of minutes, but let's see. Pharmacists run small rural hospitals, don't have a hospital background. This is everybody's first inpatient job. I need to improve their AMS knowledge in an accessible way. That is a question we've gotten a lot, and I have some recommendations. Preventing hospitality from treating candida in the urine when the patient has a Foley but no UTI symptoms. As I said, UTI is at least straightforward theoretically, but difficult in general. So let's talk about how to provide antimicrobial stewardship knowledge. So this is one of the foundations of some of these regulations. You need to have expertise, but it's a mandate without support. What I would recommend is at the very least, and I will try to put this up on the board. The CDC has a antimicrobial stewardship training module. It is completely free for everybody. It is so if you just look up CDC antimicrobial stewardship training, you will find it. Let me try to share this right now. Here it is. So this training stewardship module, it's on their site, train.org. Come on. but it is a pretty extensive training course on antimicrobial stewardship, highlighting some particularly vexing problems like what people just talked about. So urinary tract infection management, soft tissue infections, bronchitis, asthma. It is not what I would call comprehensive. It is definitely a course that has a very broad umbrella of who it's targeting. But it will provide a certificate. It will also provide the fundamental foundations of an antimicrobial stewardship program. And it is difficult to, I keep accidentally. And it will at least provide some of these foundations. So that's a good way, good free way of providing antimicrobial stewardship knowledge. Once you get into the, there are other costs involved with other trainings. So MAD ID is a big one that many facilities send their pharmacists to. It can be kind of expensive. It's a great foundation. I forgot how long it is. It's like 3 or 4 days, I think. But yes, that's a way to do things. I wish I had better solutions. This is a question that people have asked multiple times. And at least we have some options, and the CDC is trying to address this. But another thing is, that's kind of why MassSec exists. That's our goal, is to try to help improve people's antimicrobial stewardship knowledge, address the questions that are coming up so that people have some resource to go to. Other questions. It's keep pressing my keys and then not getting things. Long-term care facility, difficult at times to get antibiotic or infection information, hospitals in transition. Curious idea of using Fluorostor with antimicrobials. Evidence not showing anything. Even yes. So that is. So I used to get. I have training in quality improvement and patient safety. The transition of care between long-term care facilities and hospitals, both ways, is fantastically fraught. Yes, it is often difficult. It is better now that patients can actually often get access to their records electronically. That's often what sometimes we resort to, is just having them get their records and then looking at it when you get follow-up. But it is difficult. And there's no perfect solutions. What I would probably do is have your leadership talk to the referring institutions to try to get them to provide more documentation. There's no great solution to this. But it helps. The more people, so the more systems sort of move to electronic medical records, they are often interconnected and it becomes better. Even in my time as a steward, this has happened. But curious about the idea. Fluorostor is a oral, it's a probiotic, essentially. It is certain antimicrobials. So the unfortunate thing is, from a literature perspective, most of the currently available commercial probiotic agents don't really demonstrate impact. The belief, at least in the ID community, is that they are often kind of a placebo, in that they make people feel better about the fact that they are on antimicrobials, and it is causing impact on their gut. That's not to say that microbes can't help, but it is, at least right now, we are in the early days of true microbiome therapy. There's some of my colleagues actually work on this. At some point, it may happen, but at least Fluorostor, I'm not aware. And I can't remember which bacteria it is. Now, that being said, generally, in most patients, they are harmless or very low harm. The time when I recommend that they definitely not be used is patients who are immunocompromised, severely immunocompromised. So transplant, it's like really high chronic steroid use, or have a lot of like indwelling lines or GI, like severely disrupted GI systems, because then that bacteria can get into the systemic circulation, and that can actually cause significant problems. Yeah, so addressing and collaborating with individuals that are set in their own way and mindset despite being given guidelines. So this is where the practice of antimicrobial stewardship is not perfect. And it is what I would call a stochastic phenomenon. Realize that as an antimicrobial steward, you are not specifically taking care of the patient. I know this is really hard because all of our time as clinicians has made us focused on this way, and in trying to make every single case as optimal as possible. But as an antimicrobial steward, especially as in a larger institution, you just can't get your way on every single case. And in some cases, you're going to be wrong because you don't have all the clinical patient information. So ultimately, we have to defer to the prescribing practitioner in some cases and say, okay, we don't recommend that, but it is your decision. Now, what I will say is the more you talk with them, the more open you are and interactive you are, what we found is they come around in many cases, at least in some of the cases. And so overall, you will begin to have an impact, even if not every case you can get them to follow the appropriate care guidelines. And I'll go back to that initial question of treating Candida in the urine when the patient is a Foley. I think people who've read the guidelines know that that is not an indication for the treatment. It's not a urinary tract infection. It's not an indication for the treatment of a urinary tract infection. So this is something where you need to counsel them, try to beat it into them through education as much as possible, but realize that you're probably going to fail on not an insignificant number of cases. But the other thing is, that specifically is a case for diagnostic stewardship. You want to emphasize that people need to have symptoms, have some concern before you get a test, because that is one, especially for urinary tract infections, our number one problem is people just order urinalyses and urine cultures, and then they freak out when they find something, even if a person is completely stable. And so that's why diagnostic stewardship is becoming part of antimicrobial stewardship, because they're both part of the chain of decision making. But yeah, really hard. I don't have a perfect answer to that. But these are really good questions.
Kevin, there's a question in the chat.
Sorry.
Just about when we might be sharing a copy of our slides.
So we can provide a copy of the slides right after this to people who have attended. We are trying to develop a website. It's a little bit on the slow side, and apologies, to host all of these things going forwards, as well as some resource utilities. But we can definitely just send it to you afterwards. That's not a problem. I'm going to remove the polls though, because I don't want to accidentally erase all our poll responses. You guys have asked really good questions. All right, so special thanks to George Surablitzi and Amy Pierce and Corey Lance, who's on this call from the Missouri Department of Health and Senior Services, without which this program and our effort to make Missouri the best state in antimicrobial stewardship would not be happening. Thank you everybody for attending. I apologize that I'm about 15 minutes late. Our next meeting is June 2024. You can definitely reach us at missouristewardship@wustl.edu. That's the one single point in contact. We'll be able to answer your questions about pretty much everything. And of course, if you're interested in the intervention training program or the stewardship program and intervention training program, please tell us that way. I hope this has been helpful for everybody. And if there are further questions, I'll stay in the line for another 5 minutes, but people can get off there and go about their actual daily business. And hope people have found this useful, and we will try to address additional questions going forwards, and just tell us what those are so that we can specifically answer them next time. Thank you, everybody. Have a nice afternoon. And if anybody wants to stay online to just chat, that's totally fine too. Whew, it's hot in my office now. So yeah, as you could see, Aaron, I had a little bit more I added to the slides.
That's our.
I got to edit them now to remove all those poll everywhere stuff. Oh, poll everywhere was being really, really annoying. All right. Doesn't look like there are any questions or people sort of sticking around to answer questions. So I'm gonna head off. I think this worked really well. Oh, is there a second? Stephanie, you can just unmute. You don't need to ask it on the chat at this point. Is there any indication for using Vanc 250 milligrams Q6 for C. diff? No. So Eric DeBerkey, who I work with here at WashU, is one of the world experts in Clostridium difficile treatment. So the vancomycin given at 125 Q6, which is, I believe, the standard dose. Can't remember offhand, but I'm pretty sure that's right. Achieves extraordinarily high levels in the gut, enough to really wipe out C. diff. That's not the problem with C. diff recurrence. So the problem with C. diff recurrence, the problem with C. diff recurrence is that in the process of wiping out C. diff, you wipe out everything else too with vancomycin. And it leaves the gut, basically, the gut microbiome, the sort of environment of the gut, completely open to new C. diff, often C. diff spores from themselves, getting reintroduced and starting the whole process all over again. Now, the problem with using 250 milligrams Q6 is that actually vancomycin can be quite irritating to the gut. It is also an osmotic it's not diuretic, but it basically causes an osmotic diarrhea. So it pulls fluid into the gut, which can cause a lot more diarrhea. So it actually can be very unpleasant at higher doses, which is why it's set at sort of a lower dose. And there is no evidence that using it at a higher dose reduces the rate of recurrence. Now, for people who are at high risk of recurrence, one thing that has some effect, though it's not incredibly well studied, is a taper. Is 125 milligrams Q6 for the normal duration, then slowly tapering that off to, Q12 once a day for, over the course of a week or two. That may, what the thought is there is that may allow time for bacteria to recolonize the gut that is not C. diff. But this is the problem with C. diff in general, is just has a high recurrence rate. So hopefully that answers some of that question. Yeah. And the other thing that they should be aware of is that the diarrhea often is not completely gone at the end of a course. But that's not necessarily because C. diff is still around, but because the gut is inflamed and it's taking a while for the gut to recover. I find this a lot with my providers, except for mild cases of C. diff, they often are like so fixated on needing the diarrhea to completely go away, but all the other symptoms are better. White count's better, fever's better, abdominal pain's better. And it's just, the gut is a fragile thing. It takes time to recover, and that's not always going to happen within 10 days. Yeah. So glad I could answer that. The C. diff is a complicated topic, and I tried to simplify it. Would you recommend just letting it resolve itself or using an antidiarrheal? I recommend letting it resolve itself. As long as the patient's it's not causing other problems to the patient, like, you know, severely irritating a sacral decubitus, where, yeah, that could be a problem. I generally recommend letting it resolve itself, because the more you try to change in terms of add things that constipate the patient, or treat with additional antimicrobials, it can often just cloud the picture, cause more problems. Like, some of the constipating agents cause a lot of gas and distress, and then that you just don't want that to be the end result. So I generally recommend letting it resolve on its own, because all you need to do is tell them this will get better, but slowly, like many other infections. No problem. My pleasure. All right. Well, that's it. Um, we'll see you guys in a couple of months. In the meantime, please ask us any questions that you have. Take care, all.